Assalamu alaikum. We are starting with the clinical scenario. Mr. Abraham, 24 years with complaint of dizziness. Let's start after sharing the timer. Okay, are you ready? We can start.
Yes, yes.
Yeah, here you go.
Hello.
Hello.
Hello. I'm Dr. Abdullah. I'm a doctor in the clinic today. You are Mr. Abraham, 24 years old.
Yes, doctor.
Nice to meet you. Mr. Abraham, today we are here to discuss about medical issues. Is that okay for you?
Yes, doctor.
Okay. It came to my knowledge that you are complaining of dizziness. I'm feeling dizzy. Can you tell me more about this? What do you mean by dizziness?
I don't know, doctor. In the past 2 to 3 months, when I am walking and doing something, I feel myself dizzy.
Yes. Mhm. Do you mean that when you are feeling this, when you are from sitting to standing position?
And sometimes from sitting to standing position, and sometimes not related to position.
Mm. Okay. Do you lose your consciousness?
No.
Okay. Okay. Do you? I mean, do you faint or no?
About to faint, but I never faint down.
Okay. Do you feel that surrounding spending around you?
No.
Okay. Okay. How many times happened for you this disease?
Many times, doctor. Many time. Many time. I cannot account.
Okay, last time. Let's talk about last time for you. What do you do at that time when you are feeling? I mean, before you are walking, doing exercise, watching TV. What you are doing that time?
Not related to something or to certain activity, doctor. Even with any effort or with any movement, I feel myself dizzy.
Okay. Do you mean that this dizziness increase with exercise?
Yes, with exercise and sometimes without exercise.
If you are on rest, you are feeling dizzy also?
Yes,
You are
sometimes, doctor.
okay. uh, okay. Do you have any fits or what happened or which time take this dizzy? How long?
For few seconds, few minutes.
Okay. Okay. Do you have any jerking movement of your hand?
No, no, doctor.
Do you bite your tongue?
No. I didn't lose my
Okay.
consciousness, doctor.
Okay, only you are feeling you will faint or some black or curtain came in front of your eyes.
No.
Okay. I mean, I want to know what is the feeling, what happened, is what you feel in that when you are feeling dizzy. You will feel uh, you will
I feel,
you
doctor,
want
I
to
feel
like.
I'm out of energy. I'm not
Yes.
well. I'm not strong, and
You
so
are
on.
feeling weak.
Yes.
Okay. Any true weakness happen for you once? Any weakness? Any uh, weakness in
No.
any part of your body?
No, doctor.
Okay. Okay. Do you have any headache?
Yes. Sometimes I have headache.
Headache associated with this dizziness? After dizziness,
Sometimes
I mean.
not closely associated, doctor.
Okay. Okay. For how long you have this headache?
It is come and go, doctor, many times.
Mm. What is the nature of this headache? It is dull, achy, uh, stabbing.
No specific character, but I feel that I'm not okay in my head.
Okay. Where is the site of the pain?
No specific side, doctor. It's
Okay.
come all over my head.
Okay, if this pain increase with coughing, sneezing, or uh, lying.
No, doctor.
Okay. Do you have any raised temperature?
No,
Okay. No history of fits.
no.
Okay. You said you are feeling dizzy when you are from sitting to standing position. You are changing your position from sitting to standing. Yeah.
But not always. Sometimes this dizziness came to me even without changing the position.
Okay. Okay. Do
And
you have
also,
any?
a lot of my friends told me that you look pale.
You look pale. Okay. Since when? These last 3 weeks, 3 months.
This last 2 to 3 months, yes, sir.
Okay. Okay. Do you have any raised awareness of heartbeat?
Yes, doctor.
Is it regular?
Yes, regular.
Okay. Any also increase with exercise, this rising heartbeat?
Yes, doctor.
Okay. Do you have any cough?
No,
Difficulty of breathing?
no,
Okay. Any chest pain?
no,
Any noisy chest?
no,
Any coughing of blood?
no, doctor.
Any bleeding from any side of your body?
Before 4 or 5 weeks, I went to the emergency department. At that time, I have nasal bleeding.
Mm. And you okay, large amount this from both nostrils?
One side, doctor.
Okay. This happened for you recurrently or this one time?
Actually, 2 times.
2 times. Since when it
Yes.
started?
Last bouts about 5 weeks ago, and first one before 4 or 5 months, like that, as I remember.
Okay. Any past medical history must be aware of? Any high blood pressure, high blood sugar, any bleeding disorder?
No, apart from this nasal bleeding, no, doctor.
Okay. Do you have any surgery before? You did any surgery?
No,
Any blood transfusion?
no,
Any blood history of blood clot?
no, doctor.
Okay. Any yellowish discoloration of your eyes?
No,
Any skin rash in your body?
yes, doctor.
Where? Can you show me?
Yes, I will send to you the picture in the group, WhatsApp group.
Okay. What do you do for living, Mr. Abraham?
I'm teacher, doctor.
Okay. And this impact your life?
So much, doctor.
Okay. Not came in the group, doctor. Okay. Do you smoke?
Yes, doctor.
Do you drink alcohol?
No,
How many cigarettes you smoking?
10 cigarette per day for the last 2 years.
Okay. I advise you to stop smoking because it is affect your health. Uh, uh, okay. Uh, do you drive?
Yes, doctor.
Okay, I ask you to stop driving until we will finish our assessment. Okay, then I will come and I will update you. But till now, that time, please stop driving. Okay. Do you, can you show me your medication list?
I'm just
No
taking
photo,
برس.
doctor.
بس الشبكة شوية هنا كده
Okay.
الصورة ما
Mm-hmm.
تمشي. Yes, I'm taking paracetamol and multivitamins.
Okay. Do you have any black stool, black bowel, loose motion,
No,
any tummy pain?
no, doctor.
Okay. What about your water work? Any change in your water work, amount, color?
No, no, doctor.
Okay. Uh, okay. طيب, can I examine you?
Yes, doctor.
Okay, general list of the patient and vital signs.
Yeah, you can see the face of the patient. There is some redness, skin rash
Where?
in the nose and in the lips and in the
Mm.
cheek. بس معلش يا
Okay,
دكتور
you need
الصورة بس ما
hemorrhagic
أذكرش.
anesthesia.
Yes, yes, look like that. Yes,
Okay. Okay. He's well,
yes, well,
not jaundice.
not jaundice.
Okay. Okay. Can any like this rash in his body,
In the
anywhere
back
in his
also.
body? He
In the
has in
back
the back.
also.
Okay. Uh, okay. In these last 3 months, you have any? You said no bleeding and no black tearing motion from your back passage.
No,
Okay. Do you have any family history of nose or similar complaint?
yes, doctor. Yes, my younger brother also have same problem.
Okay. Okay. Okay, Mr. I want to examine the heart for first and second heart sound, any added sound, and no murmur.
No,
Okay. And no basal crepitation, or there is basal crepitation.
no basal cream.
Okay. I want to see, okay, inside your buccal mucosa and uh, no rash inside.
There is rush just in the lips.
Okay. Any darkness in your mouth.
No,
Okay. Once now, do you check your blood sugar when you are feeling this dizzy?
yes, it is normal, doctor.
Okay. Uh, okay. And you have no throwout, uh, no feeling sick.
No,
Okay. Any lower limb swelling?
no,
Okay. Hand examination. There is no deformity, no joint deformity, no clubbing, no splinter hemorrhage, no palmar erythema.
no,
And on the abdomen, there is no organomegaly.
no organ.
Okay. Do you lose do you lose your weight? You have any weight loss?
No, doctor.
What about appetite?
Appetite is good, doctor.
Okay. And okay. Do you have any numbness in your hand or feet? Numbness or needle
N-
sensation?
No, no, doctor.
Okay. Uh,
2 minutes left. You can see the photo, Dr. Nilsar, the
yes,
screen
I
now.
saw it. Okay.
Okay.
Okay, thank you. Okay, Mr. Abraham, what is your concern?
What is with me, doctor? Is it treatable?
I appreciate your concern, Mr. Abraham. You have a condition called hemorrhagic telangiectasia. Okay, it is a disease running family. Okay, and cause this disease, there is a problem. There is a abnormal blood channel formation that causing bleeding. This abnormal blood vessel easily damage and cause bleeding for you, and can cause for you this bleeding sometime like that you have before nasal bleeding, and maybe you have another side also. You are losing this blood and cause for you a condition called anemia. This anemia is the decrease in the hemoglobin and cause for you these symptoms. Okay, now I will do for you some blood investigation, some imaging to confirm diagnosis and to exclude other. And okay, and I now according to now you have no okay. Now I will admit you only to assess, and according to the result, then we will uh, decide to admit or not. Do you have any more concern?
Is it a treatable condition,
It is
doctor?
treatable. It is controllable. Okay. And as I said, it is running family, but is it controllable? And we will follow you. We will include our blood doctor also. Will give follow up in his clinic. Do you have any more concern?
No, doctor. Thank you.
Thanks.
Okay, time is up. The examiner questions. Start, please, Dr. Khalid.
So present your case, positive finding in history and examination.
Okay. This patient complained of dizziness for last 3 months, and he has dizziness frequently. Sometimes he has headache, and also he has awareness of heartbeat. He has palpitation, and positive family history of similar complaint. And he has a skin rash going with hemorrhagic telangiectasia. On examination, patient looks pale, not jaundice. He has a skin hemorrhagic telangiectasia in his face and in his upper chin also, and in his lips. And he has no sign of complication of the anemia, any anemic complication. From that, my differential diagnosis first is hemorrhagic, hereditary hemorrhagic telangiectasia. This patient, he has this complaint from anemia due to hemorrhagic hereditary telangiectasia. Okay, maybe other causes of anemia, maybe B12 deficiency, but patient he has no any numbness, any tummy pain, any needle sensation. Okay, maybe he has dizziness from Addison also, but he has no any tummy pain, no throwing up, no dark skin in his
Okay. What type of anemia you expect in such a patient?
most likely he has iron deficiency anemia.
Okay. What other causes of iron deficiency anemia in such age?
Maybe also maybe malignancy, but it is just likely because patient he has no weight loss, no fever, no any constitutional symptoms. Okay.
Okay. How would you investigate such a patient?
General investigation, specific investigation for complication. General investigation, I will do full blood count, renal function test, liver function test, inflammatory marker, ion study. Okay, I will do serum ion, serum ferritin, serum transferritin. Okay, I will do for him endoscopy also to check if there is any endoscopy and colonoscopy for any inside bleeding, any blood bleeding, okay, or any telangiectasia inside, okay. Also, I will do for him ECG, echocardiography, and
For what?
because he is complain of palpitation, also most likely from anemia, but to exclude other, okay.
Okay.
Also, I will do serum B12. I will do any autoantibody, but less
Okay.
likely.
Okay. If this
Okay.
patient came with fits, what is the possibility?
Most likely, maybe he has subarachnoid hemorrhage. because of this bleeding inside his brain.
Okay. So how you will treat this skin rash?
Uh, Non-pharmacological, educate the patient about the disease, and also I will counsel him. I will refer him to multidisciplinary team. Pharmacological, I will give him iron supplement, treatment of the anemia. Okay, I will give iron. And
Regarding skin rash.
skin rash, I don't know what I can do. If it is more bleeding, we can do embolization, I think. Or also, I refer him to the genetic counseling, genetic clinic.
Refer to dermatologist. Okay, thank you, Dr.
And
Antisar.
okay, thank you.
Okay, still 20 seconds, Dr. Khalid. Do you have more question?
No, actually, no.
Okay, can I ask here some question?
Welcome.
So, Dr. Ansar, what the cause of nasal bleeding in this patient?
Most likely he has telangiectasia also in his nose.
Okay, what other possible cause of blood loss in such case?
Maybe simple trauma, maybe high blood pressure can cause blood patient. He has no any history of high blood pressure.
If patient came to you with
Maybe
hemoptysis,
local cause.
What do you think? Last question.
Hemoptysis, maybe also there is a telangiectasia maybe in his esophagus, or okay, or maybe
Okay, hemoptysis, not hematemesis, hemoptysis.
hemoptysis. Sorry, hemoptysis, coughing of blood. Maybe also he has
What's called? Give me a term.
what?
Give me
Sorry.
the term of the complication, the term of this condition.
The lesion, name of the lesion.
Yeah,
Really, I'm not sure. I don't know.
Dr. Khalid?
AV malformation lung.
Yes, exactly. Yes. Okay.
Okay.
Let's hear the comment, then I will comment. Thank you.
ثانك يو دكتور انتصار ويل دان. يمكن بس الشير بتاع الصورة اتأخر عليك عشان كده. You didn't get the clue. You did well analysis for the dizziness. Exclude the neurological والcardiac causes. Then this we generate this case to go in the pathway of dizziness of anemia. As we know, the other pathway of dizziness, neurocardiogenic and cardiogenic. So you get little hesitated in the start because of big complaint and big
Yeah.
yes, exactly. So I can
Because I don't know what you exactly mean by dizziness. I want to know. Okay.
Yes, yes, yeah. Unless you see the patient, very difficult to exhibit.
Yeah.
Yes, but you did well through the structure of the history. Nice. A few points, Dr. Basir, about the hereditary hemorrhagic telangiectasia. Yes, it is a cause of microcytic anemia, or causing anemia. And unfortunately, people will try to research about other causes of anemia. Anemia will be, for example, مثل mal absorption anemia. Should ask about the GIT symptoms, mal absorption diarrhea, and also maybe due to malignancy, and she has asked about the general symptom well, and also maybe GIT loss. She asked about the black stool and so on. Here the patient is male. Also, if she is female, we should ask about the menorrhagia and period and so on. And important, we should ask about the diet and how the lifestyle of the patient regarding the diet. Is it vegetarian? Is it like that? Regarding hereditary hemorrhagic telangiectasia, diagnosis mainly clinically. There is four criteria. Three out of the four criteria can make the diagnosis. First degree relative with similar condition, and also Dr. Tisar asked it about it. And second thing is spontaneous recurrent epistaxis, and this patient have two bout of it. Another thing, if there is visceral AV malformation. AV malformation may be in the brain, in the lung, in the hepatic AV malformation. I mean internal organ AV malformation. Fourth criteria, it is multiple telangiectasia. So we can summarize three out of the four criteria can diagnose hereditary hemorrhagic telangiectasia. Family history, spontaneous recurrent epistaxis, visceral AV malformation, multiple telangiectasia. And also we should cover in the history اللي هو hemoptysis as Dr. Basil said, and any CNS symptom like jerky, fits or headache, and so on. Usual presentation of hereditary hemorrhagic telangiectasia by recurrent epistaxis. Epistaxis management acute setting, backing, and tranexamic acid may involve ENT specialist for nasal cautery, nasal coagulation, sclerotherapy. Regarding telangiectasia, dermatologist referral and can do laser therapy. If the AV malformation, lung or hepatic and so on, treatment may be surgery or through interventional radiologist to do embolization. Thank you.
Thank you, Dr. Khalid, for the case. Nice case. So the topic of dizziness in the faces is very common. And you have to know, Dr. Insar, what you are going through, what the cause. You went initially like confused because you don't know what the main cause. But he gave you a clue. He told you since the start, I am feeling dizzy or without or not related to the position, sitting, standing. So you have something systemic. It's not postural hypotension, right? So
Yes.
either you will go the pathway of postural hypotension or some systemic disease, which is anemia. I guess this is the clue for the case. Since you have any feeling dizzy while sitting without standing, of course it will be worse with standing from sitting. So this is anemia. The other pathway for postural hypotension, you will think about Addison, you will think about autonomic neuropathy, you will think about the medication, dehydration, and some diuretics, drug induced. Okay, so either this or this. The other possible cause will be the cardiac cause, and you rule it out any feeling heart racing before the attack. You try to get the clue from him. You ask him many times, what do you feel before that? He's not feeling because this is always while sitting. So it can happen without even moving or standing because of anemia. Actually, severe anemia. Be having these symptoms should be severe anemia. Okay, let's go back to the other cause. Let's count them again together. The possible cause in the bases and the common. First of all, Addison and Lucia hypotension. This is the top. They are bringing the frequently. The second cause will be cardiac one. Cardiac, they will bring either arrhythmia or HOCM, aortic stenosis, or whatsoever, okay? Then the epilepsy as a cause of feeling dizzy or fainting or falling down, loss of consciousness, and vasovagal attack, syncope, I mean vasovagal syncope. And the biggest topic is anemia. Hypoglycemia one off, you should roll it out, but it's not coming as fainting only. It might come with an awareness, hypoglycemia, or diabetic complication. Okay, but syncope or dizziness or fainting in paces, it will be One of these I mentioned earlier, either Addison and Bush hypotension, medication, all causes of Bush hypotension, or cardiac causes, it will be with exercise, mainly with exercise. But it might happen even with the stress, like Hocum. Okay, so the clue will be palpitation before feeling fainting. The third cause, the epilepsy, and you will have the causes of, or the manifestation of epilepsy: biting the tongue, loss control, and wetting himself, and biting the tongue I mentioned already. Post-ictal state, he will be confused for some time. And our case here, anemia and the hypoglycemia, by asking for the shakiness and feeling sweaty, low blood sugar by checking the RBS, patient already on insulin, they didn't take his diet. These are the five causes in basis. It will not be out of these. Okay. But the clue for anemia, as Dr. Khalid told you, I feel it all over. Sitting, standing, it's not related to position because of the fatigue, because of the low hemoglobin. Okay. And also the other clue will be the pallor. He will tell you, or you can ask him, did you feel or anyone told you you are paler than before? Okay. Plus the other questions for bleeding. Do you have any attacks of bleeding from anywhere from your body? Any blood thinning medication? You have to ask this question. You didn't ask it. Any blood thinning
Mm,
medication? A patient might have
yes.
warfarin, anticoagulant for AF, and over anticoagulated, he will have melena frequently, and he doesn't know this is the reason of the blood of the anticoagulant and the blood loss. You have to ask this question. Okay. So
Okay.
again, back to question of bleeding from anywhere. You have to ask specifically if you suspect such condition. You have to ask specifically from the nose, from the mouth, cough of blood, and sorry for this question, any black back passage, or tarry store, or offensive stool, black, dark,
Black
whatever,
motion.
or even blood coming from your, sorry for this word, from back passage, even fresh blood. And hematuria, you can ask also any blood coming in the water work. Okay, and don't ask two questions. Any change if your water work color or amount, or no, make it one by one, because the surrogate will answer you for the last question. For example, if you said any change in the color, amount, and frequency, he will tell you about the frequency. Yes, I'm going frequently. But he will not tell you about the blood. I didn't notice any blood. He will not tell you unless you ask him any blood, for example, in your water bottle. Okay, so let's go back to the blood loss in this patient. Any blood loss from any orifice he might have. So you have to ask specifically. Even he will deny, you have to show the examiner that you are asking all these questions. You got the diagnosis right. He told you I
Yes.
have skin lesion. This is, of course, this is telangiectasia. Even without sharing the picture, Dr. Khalid, no need to wait. All of us, I guess, the case from the prescription, or sorry, from the description of the lesion. I have some skin lesion in my face. So what it will be? In face is either systemic lupus, butterfly lesion, or telangiectasia. No more lesion in the face. Okay, so you have to specify the question of blood loss in such case. HHT, he will lose blood from anywhere. Okay, you have to specify the question for blood loss from all the orifices in the body, but don't say orifice, from any area from your body. And blood thinner question, you have to ask family history, as Dr. Khalid said. Let's go back to the complaint and the serious form of the complaint. Why I ask this, and every day I'm repeating this question, because you will admit this patient or not. What do you think, Dr. Intisar, about admission of this patient? You tell me.
Okay. This patient, he has no any red flag. He has no any sign
How
of heart
come?
failure,
How do you
no
know?
shortness of breathing, no,
Okay, what about dizziness? Is it accepted the patient will have dizziness?
no, but not for admission. I
So
can
it's
leave for him.
symptomatic anemia. It's symptomatic anemia. This is one of the symptoms of anemia, right?
Yes.
So when he let's ask me. I will ask you the question from other way. Do you
Mm.
think all HHT patient will be anemic?
No.
Of course, no. Yeah, why? Because they have frequent blood loss. It's not
Mm.
one
Yeah.
attack. So from one attack, either he will be anemic if severe blood loss or big amount or profuse bleeding, or maybe some epistaxis, which is controlled by compression or whatever. So when he will have the dizziness, what do you think?
This maybe means severe anemia.
So you will admit or not? So this is the question to the patient.
Mm.
I mean, to show the examiner that you are caring for the patient. You are feeling dizzy while sitting. It's severe anemia, not only anemia. It starts usually with standing from sitting, but when he reached to the level of or the extent of being dizzy while sitting, mean he's severe anemic. And he told you, I am pallor. I have pallor. Some friends told me you are pale than before. So definitely he's the symptomatic anemic. So this question just to show the examiner that you are caring for the acute or the red flag. One of the red flag is the dizziness, the palpitation. You will not wait for him to tell you, yes, I am short of breath, doctor, and I have leg swelling. I mean, anemic heart failure. This is more indication to be admitted, but still he is indicated for admission. So you have to ask for the red flag, and you ask already, but you didn't decide. You said, I will admit you to check, then I will admit you. No, you will admit him to check for, and you might need blood transfusion. You have to do this advice while talking to the patient. And after that, to the examiner. Will you admit? Yes. Why? I will check for his hemoglobin. If low, I will
Mm.
transfuse blood. Why? Because he's symptomatic anemia. So you have to tell the patient as well as the examiner. I might admit this patient to check his blood hemoglobin, and he might need blood transfusion after multidisciplinary team approach. This will be first point and first mark for the clinical judgment. You give good decision, you admit the patient, you give him blood, which is need now. Okay, let's go back to the
Okay.
history. You analyze the other symptoms, the GI, any blood loss upper or lower. But whenever you mention, you have in the examination, you have to offer digital rectal examination. Definitely, you have to. He might have some
Mm.
blood loss and he doesn't know. He might
Mm.
didn't see it, right? Not
Mm.
all patients discovering if he has blood loss or black stool. Maybe it's occult blood. So you have to do digital rectal examination or offer it. He will not accept, of course, to do it, but you have to offer it. You have to offer blood digital rectal examination. You have to offer examining of the mouth cavity. You have to check for the telangiectasia, even in the mucous membrane, and the epistaxis. You have to refer to the patient to multidisciplinary team to check for any nasal bleeding or any telangiectasia in the nasal mucosa or residual blood or whatever. Okay. Apart from that, you did the social good, the family history. You discover, and he has family history of. You can give also advice about this. If your brother also have the same symptoms, please let him contact with us. We can manage him as well because he might not also know the diagnosis.
Mm.
Family travel and past medical history. Good question you ask, because if you are lost, you have to ask this question. Even if you are not lost, since the start, you can ask this question. You might know the patient already on some anticoagulant blood thinner medication, and it will be the reason. I mean, another case, not this case. This case is clear for HHT, hereditary hemorrhagic telangiectasia. The examination also of telangiectasia, you have to press over it to check if is it blanchable or not, and offer it. Okay, they might feel it's discomfort, but offer it. If he said yes, you can press over it and see if it's blanchable or not. Okay, this is for the
Okay.
examination and the history taking. The concern, you talk long to explain the disease. Be simple while explaining the disease. if you want to say about any familiar condition, you can just say this is familiar condition which runs in family, in which the disease there is defect in your blood channel. That's why you are losing blood. That's it. From where it might be from the liver, from the kidney, from the bowel, from the nose, from the lungs. Okay, and give him some time to give you another concern. You might have three concerns. If you answer one concern lengthy, you will lose the other concerns, and they are deducting for that for this. You have to ask for all concern and to address all concern. Okay. For the differential, what you mentioned in the differential for this patient.
I said the hemorrhagic telangiectasia.
Okay.
Mm. Also, I
What?
thought maybe
So you have to give differential for anemia or dizziness.
dizziness. Yes. So I thought maybe Addison disease, Addison syndrome, but there is no tangsten, no
Yeah, you can
uh,
say that. And
no
what the third cause of dizziness?
other maybe
You can say
neurological, yes,
cardiac.
but no neurological
Oh,
deficit
yes, you
or
can say. So
neurological.
the four causes we mentioned. Okay, if he asks you what the differential of anemia is, this patient, young patient with anemia, what do you think?
Yes, iron deficiency anemia.
Okay, this patient is already iron deficiency anemia. What else?
What else?
Young
I
Maybe
patient.
lost.
B12, maybe from the dietary. Okay, maybe
So you have to ask about
autoimmune,
diet.
maybe
Okay,
hemolytic.
excellent. This is the most, you have to mention this one, hemolytic anemias. A young patient with blood loss or with anemia, frequent transfusion, in such age, you have to put hemolytic anemia in the differential. Sickle cell, thalassemia, hereditary spherocytosis, all these causes will be under the term of hemolytic anemia, and you have to put it if he asks you what the differential of anemia in young patients.
Mm.
Yeah, iron deficiency, it's not common in young patient unless he has such condition, HHT. But as
Yes.
iron deficiency, blood loss, chronic blood loss, it will be with cancer colon or duodenal ulcer with elderly patient taking antiplatelets and so on. Or maybe young patient and he's dependent on non-steroidal, and the non-steroidal also lead to peptic ulcer disease. So he's losing blood and it will lead to iron deficiency anemia. But don't forget the hemolytic anemias. Vegetarian, yes, you can mention the vitamin D deficiency because of vegetarian, because a vegetarian regime, some young patient or some young people are following this kind of regime. I mean, being vegetarian. Okay, I guess we covered the topic of HHT, the question, the investigation. Yes, the investigation you have to mention, of course, the basic CBC and to tell him for hemoglobin. And while talking to the patient, you have to say it's low blood count, not low hemoglobin. He doesn't know what the meaning of hemoglobin. Low blood count, okay, as non-jargon.
Mm.
You might
Ah,
have low blood count. That's why you
okay.
have these symptoms, low blood count.
Mm.
Okay. For the other investigation, echo, as you said, ECG for heart failure, and for the AV malformation in the brain, you have to do CT,
CT also for
CT
with
angio
any
or
malformation.
MRA, CT angio or
MRA.
MRA. In the
Mm.
chest, you might do
Uh,
same CT angio.
HSPCA is
CT angio. Angio mean vessel. So you suspect AV malformation, you have to do CT angio. And sometimes they are doing echo bubble study. Okay. For the bowel, what you suspect the bowel will have? Because you mentioned it to
yes,
the patient. What's called
yes. AV malformation, yeah.
angiodysplasia.
Uh, but this
Okay.
for hereditary.
Yes, it's still a manifestation.
Okay.
Okay. AV malformation for major vessels. In the bowel, it's angiodysplasia in the vessel of the gut. And also in the liver, you might have also AV malformation. So you can do CT angio all through. But for the brain, you can add MRA. Okay. The management definitely acute, if acute presentation like this patient, ABCD, oxygen, transfusion. If patient hypoxic, of course, he might be in failure. You can consider heart failure management. So ABCD approach. Then multidisciplinary team, including genetic, including hematologist, including the ENT and gastroenterology. All teams will be involved. Blood transfusion is the first management plan step. You have to transfuse the patient or not. You have to mention the blood transfusion. Okay, sorry for being lengthy talking. Let's go to the next scenario. Can you please share your scenario? Yeah, good.
Yes, yes, in the chat box.
MashaAllah. Okay, good. Mr. Omar, 57 years with complaint of vomiting. Dr. Khalid, when you're ready, let me know.
There is specific treatment for telangiectasia.
Specific treatment? No, according to the existing blood vessel or existing AV malformation. For example, let's start from the brain. If you have AV malformation in the brain, what you will do? We have two options, either coiling or clipping. Whatever, you have to specify the team there, it's neurosurgeon. If you discover, for example, AV malformation in the brain, but you have to interfere with, because if you left with untreated, it might bleed suddenly and the patient might lose his, it might threat his life and he might die. Or he will have epilepsy or seizure, or he will have lateralization, neurological deficit. According to the bleeding, it might be either profuse bleeding with threatening his life or just mild bleeding according to the size of the AV malformation, the existing site, the side also right and left or bilateral or whatever. This is for the brain. Okay, what about in the lungs? Oh, sorry, let's go to the nose. If you have nasal bleeding. Again, ENT first, referral, and they might do cauterization. According to the local cause or the local area of bleeding. The gastro, if you have gastroenterodysplasia, what you will do? Refer to the gastro and you will do endoscopy with ligation or injection, sclerotherapy, or whatever. And the liver, mostly they are not doing anything, but anyway, you have to refer also to hematology and they will manage accordingly. This is the best answer for any multidisciplinary or multi-organ affection, multidisciplinary team involvement, multi-organ affection, multidisciplinary team involvement. Then the next step, if he asks you what you will do, you can tell him medical management, but in this patient, no medical management. Maybe they are using tranexamic acid in the acute bleeding. But if for the long term, nothing, just follow up and supportive management, folic acid, vitamin supplements, iron supplements. That's it, but no specific medication to be given such condition. Unless he is bleeding or profusely bleeding and in heart failure or anemia, symptomatic anemia, he will be referred to transfusion, but no specific management or specific pharmacological treatment. Okay, so you can just give him some supplements, iron replacement, some vitamin replacement, and that's it. Clear? By the way, again, the examiner will not go deep in details of management. If you start to say ABCD, if you start to say multidisciplinary team, non-pharmacological, pharmacological, non-pharmacological, like what? Like education, counseling. Please avoid any sports, any contact sports, boxing, and whatever. Because, for example, if he told you I am boxer, will you allow him to do this job? Of course, no. He will have one punch and he will bleed a lot. So it's like prophylactic rather than and preventive rather than treatment or therapeutic. You have to prevent the bleeding. How? Because any trauma, any stress might lead to this bleeding. Okay. Any question, any comment for this condition or this topic before moving to the next? If you're ready, Dr. Khalid, let's start.
Yes, you can start.
Okay, go.
Hello, I'm Dr. Salhouri, one of the doctors in the clinic today. Am I talking to Mr. Omar, 57 years old?
Yes. Hello.
Mis- Mr. Omar, we are here to talk to you and examine you and address your concern. Is that okay?
Okay.
Mr. Omar, it came to my knowledge that you are bothered with throwing up. Can you tell me more about that?
Okay, doctor, I have vomiting for these last three about 3 weeks to 1 month now. Everything I'm eating, I will throw. Or a lot of days, I'm I'm throwing up. I have vomiting.
I'm sorry for that, Mr. Omar. We are here to help you as much as we can. So this is first time to suffer such a problem in the last 3 weeks?
Yes,
Okay. How many bouts per day?
3 to 4 times.
Mhm. This throwing up start suddenly or it is built on a time?
Sometime like that, sometimes.
Okay. So when you throw up, this throwing up go far or just is it forcible? I mean,
No,
no. Okay. So you observe anything make it worse, like certain type of food or when you eat?
no.
Mm. Do you observe anything make it better, like being fasting or so on?
Sometimes, yes. If I'm not eating, it's better for me.
I'm sorry for that. So do you have any tummy pain?
No,
Any acid reflux or heartburn?
no pain, but I'm like fullness, some discomfort, but no pain.
Okay. So
Heart
any
pain sometimes.
what?
Sometimes I have heart pain.
Okay. Any difficulty in swallowing?
No,
Any mouth sores?
no,
Okay. Any loose motion?
no.
Any tummy distension?
Mm, yes, I'm feeling tummy distension and I have sometimes I lose motion, but not more. Two to three, two to three
What?
times a week.
Mhm. This loose motion, what is the color of it? Is it black,
No, no, no,
contain slime?
no,
Okay. So you told me sometimes you have you observe tummy distension. Is it all over your tummy or certain place?
not distension. I'm feeling fullness in my stomach, but not distension in my tummy.
I'm sorry for that. So you have any tiredness?
Yes,
You have any high body temperature?
no,
Any loss of weight?
no,
What about your appetite?
not good because of this. I'm feeling so because I'm not. If I'm not eating, I'm better.
Okay. Any lumps or bumps everywhere in your body?
No,
Any sweating?
no,
Any history of cancer or nasty growth?
no.
Okay. Do you have any long-standing condition I should be aware of?
Yes, I have diabetes for the last 20 years, and I have hypertension also.
Okay. Sorry, diabetic for how long?
20 years.
Okay. What do you use for this high blood sugar?
I'm using insulin Mixstar, uh,
Mhm.
30 unit morning and 15 at night. And also I'm using metformin and Sida. sitagliptin, I started it. I now 3 months.
How about your control of high blood sugar? That test done every 3 months.
9.
Okay. And do you have any vision problem?
Yes,
What kind of vision problem you have?
I have blurred vision.
Since when?
Since this last year,
Okay.
I'm not
Any headache?
doing. No.
How about your water work? Is it increase in frequency?
Yes, not so increased, but it is, yes, it's increased. Yes.
Increase. Any frothy water work?
Yes, I noticed like that. Yes.
Frothy water work.
Yes.
Okay. Any leg pain while you are walking?
No.
Any pins or needle in your lower leg?
Yes.
Okay. Any ulcers in your foot?
No.
Okay. Do you have any chest pain?
No.
Any difficulty in breathing?
No.
Any heart racing?
No.
Any skin, any joint pain?
No.
Any skin rash?
No.
Okay. Uh, do you drink alcohol, Mr. Omar?
Yes.
How how much per week?
Occasionally.
Do
About
you smoke?
yes,
How
for this
many?
last 20 years.
Okay. What is your job, Mr. Omar?
Mm, I am a taxi driver.
Okay. How this symptom affect your job?
Yes, because yes, it affects me really.
Hmm. I'm sorry for that. We will try to help you regarding treating condition and involving other worker, other teams.
Okay, thank you.
Okay. So, Mr. Omar, do you observe any change in your white of your eye?
No.
Okay. So, can I examine?
Okay.
General look of the patient?
Patient looks well. I mean, little showy obese, and his vital sign, it is okay.
Okay. A hand, any digital ulceration, any rough skin,
No.
any sign of needle prick?
No. Yes.
Okay. So, pulse, you said it is okay, right?
Yes.
Blood pressure is okay, right?
Yes.
Okay. I will assess the vision, visual acuity, endoscope.
There is a reflexive change.
Okay. Chest examination, heart examination, apex wear and auscultation, mitral, tricuspid, pulmonary, aortic, and carotid.
It is normal.
Normal, okay. Chest auscultation, breath sound.
Mm. Breath sound is normal also.
Okay. Abdominal examination by inspection, any distension,
No.
superficial palpation, any tenderness everywhere in the tummy,
No.
no organomegaly,
Yes.
normal, okay. I will check for the site of injection of insulin, tummy wall or thigh.
Mm. Yes,
No lipodystrophy, no.
very, very lipodystrophy. Yeah.
Okay. Lower limb examination neurologically or
Uh, there
sensory?
is there is peripheral neuropathy.
Peripheral neuropathy. Okay. Sensory or sensorimotor or
Yes, sensory is more.
okay. So, Mr. Omar, may I know your concern?
Mm. What is this vomiting, doctor? Really, I'm
I
suffering more.
appreciate your concern, Mr. Omar. After I am talking to you and examining you, and in this background of having high blood sugar for a long time and being uncontrolled, this is uncontrolled high blood sugar for a long time affect many nerves in the body. One of it is that nerve supply the stomach, make it not digest well. Any
Mm.
other concern, Mr. Omar?
It is treatable?
I highly appreciate your concern, Mr. Omar. Yes, there is many intervention we can do to help your condition.
Mm.
First, we will try to make your high blood sugar control, and we will give you some medication to helping regarding this issue.
Okay. May I need surgery?
Uh, for now, uh, difficult to answer this question, but let us to do for you further investigation, and then we will update you with what will be.
Mm. Okay.
So, um, do you have any other concern, Mr. Omar?
Mm. Okay, doctor, because my GB is not happy about my result of this hemoglobin A1C, and he asked me.
Yes, Mr. Omar. This blood sugar, yes, being 9, this hemoglobin A1C, it is uncontrolled. We try to make it control and proceed further for intervention. Okay, Mr. Omar? Hello?
2 minutes left.
Hello?
I guess Dr. Intisar out. Disconnected, I guess. We will wait for her, Dr. Faris, sorry.
Mr. Basit, طلعت?
Yes, she's not with us.
I was just, I think I forgot 2 points. I will dig more in her diet and compliance to diabetic
Yes,
medication.
you lost. Yeah, you missed a lot of
Yes,
things. So you have to
yes,
focus. You have 2 minutes, okay?
yes,
You try to
yes.
finish all these important points.
I will dig why this high blood sugar not control. Is it medication related or diet
You
related?
have a lot of
Or,
things to do. Yes,
yes.
focus.
Actually, forgot.
Sorry.
Okay, we can resume the timer. Go ahead.
Hello?
Now examine the question, or you stop the timer?
No. Still, he has 2 minutes left. Still, we are in 13. Okay, he will continue asking some questions. Yes, please.
Mr. Umar, how about your diet? Are you adhere to healthy diet?
I'm fine.
Yes. Oh, how about your exercise?
Also, not so good.
Okay. Do you take your medication regularly? You are compliant with this medication?
Yes.
Okay. So you told me, sorry, your waterworks sometimes become frothy?
Yes.
Since when this?
I noticed in these last 3 months.
Okay. Okay.
Any advice?
What?
Any advice?
Advice about your diet first.
Okay.
Yes. And meanwhile, for now, we will admit you, as we said, and we will run for you a series of blood tests, and also we will involve the eye doctor so he can regard against your vision.
Okay.
Okay, now
Thank
time
you.
is up. Yes, time is up. Let's go to the examiner section. You can start the first stuff.
Okay. Can you present your case, please, Mr. Khalid?
This is a 57-year-old man with background of 20 years of diabetic, poorly controlled, came with retractable vomiting for the last 3 months, for the last 3 weeks, and he also have impaired his visions and and sign of peripheral neuropathy with sign of kidney affections. On examination of this man, there is diabetic retinopathy, and there is sign of peripheral neuropathy. My summary of my finding feature going with uh, uncontrolled diabetic mellitus with complication for further workup.
Okay. And what more? What else?
What else? First, we will need to admit this patient with urgent
No,
ophthalmologic.
about differential. Any more differential?
A differential diagnosis in the view of this froth urine also may have kidney affections. Also, this may,
Differential for the complaint, Dr. Khalid. What possible cause? What possible other causes for this vomiting?
possible other causes, diabetic gastropathy as a side effect of as a complication of autonomic neuropathy causing this vomiting. Another may be medication related and maybe renal impairment.
Okay. And what about if another, like gastroenteritis, GERD, peptic ulcer also?
Yes, and the history of heart care, yes.
Yes. Okay. How you will manage this patient?
First, a multidisciplinary team in the form of endocrinologist, gastroenterologist, and ophthalmologist, and specialized nurse, and the dietitians, dietitian, and run for an ophthalmologist also, and run for him basic investigation, including renal function test plus electrolyte, liver function test, hemoglobin A1C, fasting blood sugar, urine analysis, and maybe need gastric studies, and abdominal ultrasound, kidney ultrasound, and also urine for albuminuria, and
Albumin
nerve
creatinine ratio, you mean?
albumin creatinine ratio, yes, and nerve conduction study for this peripheral neuropathy.
Okay. And also this patient, he has complained also, he has dizziness also. Okay. As portal hypertension also. Okay. 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 And what about you refer him for retinopathy for what?
He
How
need urgent ophthalmological assessment.
as soon as possible, yeah, because now he's
Yes.
pre-proliferative. Okay. Uh, and okay, what how we will manage this patient? How we will treat? I mean, pharmacological.
Pharmacological treatment. This patient with diabetic retinopathy, uh, for insulin definitely, and he already.
He is on insulin already. I mean, for this gastroparesis, what you will give him?
Gastroparesis first, we will control the diabetic.
Yes.
Then we can give a prokinetic agent. Then we can go to gastric pacing.
Okay. Prokinetic agent. Okay. Like
Like broken, like
domperidone, erythromycin.
domperidone,
Yeah,
erythromycin.
erythromycin. Okay, and also um, okay. And what other complication this patient can also? He has also sometimes attack of hypoglycemia.
Yes, maybe hypoglycemic and awareness.
Okay. Okay, this patient also uh,
What?
you advise him to stop smoking?
Yes, I think that.
Really, I'm not sure, but I think you didn't advise. Yeah, يا جماعة, you advise me or no? Okay, and also about driving. I am taxi driver. Okay, you must also, I think you, because I told you I have blurred vision. So
Yes, must
also
stop the right.
you,
So yes,
yes,
stop
you must stop driving until to be assessed by the eye doctor. Yeah.
yes. Mm.
Okay. Uh, okay, Dr. Khalid. Okay,
Yeah,
بس
thank you.
thank you.
Time is
بس
up.
انت حتى يعني انت you get diagnosed خلاص ما يعني you didn't must you have a lot of time. You can ask more and more and more. All the differential, all the systemic review, all because you have time, yeah.
Yes.
But you are okay.
Okay, thank you.
Thank you.
Any other comment?
No.
Okay, well done, Dr. Khalid. Nice case, really, Dr. Insan. Gastropathy and poorly controlled diabetes. I like the case because diabetic might come with every complication you can imagine. This one can be one of the presentation, peripheral neuropathy, retinopathy, nephropathy, autonomic neuropathy, and awareness hypoglycemia. All these things can come up. And you have to rule out every single complication with any diabetic complaint. If the patient came to you with any complaint, you have to rule out the all other complication. And the hypoglycemia, the most serious complication ever in the diabetic patient, because it's life-threatening one. So let's talk about the complaint itself, the vomiting, and the serious form of the complaint is a massive amount of vomiting. You suspect dehydration, right? Especially if for long-term vomiting. You have to specify the hydration or the fluid status, analysis of the fluid status of the patient. He might be in you can ask him either by direct question or by direct examination. Any dry mouth, any dry mucous membrane, any dry skin, and be sure if the patient is vomiting for long time, he might have another complication which and you have to ask about any tummy pain, any feeling dizzy, and any feeling unawareness. What will be this complication? If you have patient with abdominal pain, frequent vomiting, nausea, high blood sugar, very high blood sugar, what you suspect? DKA, right? Diabetic
Hyperosmolar
ketoacidosis.
complication.
Hyperosmolar or diabetic ketoacidosis. Both of them can happen as a complication to repeated vomiting, and it might also lead to the vomiting. So both conditions might lead to each other. The vomiting might lead to DKA, and the DKA might worse the because of acidosis, might worse the vomiting and abdominal pain. So let's go back to the complaint, analysis of complaint. Vomiting, you have to analyze the vomiting more, the amount, the nature, the content, food, color, blood. I guess you ask most of them, but you have to analyze more. Is it related to the food, after the food, breed, after, related to particular time, any medication before it? Because as you said, it might be complication or drug induced or medication related. Metformin, one of them, it might lead to GI upset. So you have to ask this question, is it related? Did you start any medication recently? It might cause this vomiting. Antibiotics, for example, any recent infection. The medication list is very important. And you have to ask specifically any added medication for related to the onset of the complaint. Or you increase the dose of some medication, or you change the medication, or you add another medication. You have to ask all these questions if you want to know is it medication related. So this is the first medication related, or as we know, gastropathy in this patient, poorly controlled diabetes, and DKA as a complication might be presented with vomiting. So all this can be differential for this patient. The GERD, as Dr. Sar said, it's one of the possible cause. GERD patient has some reflux, that's why he's vomited, and so on. Let's go back to the complication. You finish already the analysis of the complaint and the differential and the serious form of the complaint. As I said to you, he might present with DKA. This is serious, and you have to admit the patient for. What he will have confusion, high blood sugar, very dry mouth or mucous membrane, dry skin, or signs of dehydration. You have to admit this patient for. And the other possible serious complication will be hyperosmolar, as you said, also will be presented with severe dehydration. These are the possible uh, life-threatening or high serious complication related to the vomiting. We'll go back to the diabetes itself, how to analyze the complication starting from the head down to the toe. The head, You will ask about stroke or mini stroke, right? Then for cardiovascular, or let's finish the brain first, the brain and the eye. Retinopathy, you did it. Any blurring of vision. And since or once you have blurring of vision, address the driving. And you already addressed, but you didn't advise him. Are you driving? Yes, I am taxi driver, so it's more indicated to stop him from driving. It's harming him and harming others. You have to stop him. Okay, so you can say to him, please, you can stop driving until we or you can also inform DVLA because I don't know he can drive back or no. He should be controlled and he should be treated with the retinopathy or maculopathy or proliferative or whatsoever in his retina. Then this for retinopathy, then you will go for the cardiovascular, any heart attack. You have to ask about heart attack or chest pain or palpitation, feeling heart racing. Then for the abdomen, gastropathy, this is our case here. Any bloating or change of bowel habit, diarrhea associated with the vomiting. Also, it might be medication related or as complication of diabetes, the gastropathy. And you can suspect also bacterial overgrowth. It might happen with this patient as a complication of diabetes or poorly controlled diabetes. Then the kidney, genitourinary, nephropathy. You can ask him frothy, no, frothy urine, not feeling frequently going to the washroom because he will go, of course. Still, he is diabetic and he's a poorly controlled diabetic. So the question here, not how many or how frequently you are going to the washroom. He will go frequently, but you can ask this frothy urine. Makes sense to ask about the frothiness of the urine because since he's diabetic, he will go frequently to the washroom. If you want to tell him or to ask this question, are you going frequently to the washroom more than before? If you want to know to show the examiner that you are asking about polydiabetes. Anyway, both of them you can ask, but better to ask about increase the frequency, not frequent. He will go frequently, but increase the frequency to going
And I'm
to
fearing
bathroom.
from kidney shutdown.
Okay, so you can, yes, yeah, good,
Yes,
yes,
yes.
good point. Yes, I agree. Yes, if he is on the stage or he's going to be chronic kidney disease, yes, it will be reduced amount. Yes, good. Okay, accepted. So back to the complication, then uh, the vasculopathy in the legs, as you ask for claudication. And the last thing, the ulcers. You ask for the ulcers, but you can say better any sores in your leg or in your feet. And the peripheral neuropathy as also microvascular complication. These are the complication from the head down to the toe. And you can ask after that any hypoglycemic attack. Did you face any hypoglycemia recently? Are you feeling them or no? Because awareness is different than an awareness. If he has it, he will be more risky for having an awareness hypoglycemia in the next time. So you have to give him some advice. What also we missed here, the autonomic neuropathy. You have to ask about postural hypotension, feeling dizzy while standing from sitting. And the other question will be impotence. You have any, sorry for this question, you have any problem in your intimacy? Yes, you can ask him, sorry for this question. May I know what? He will tell you, I can't start or I can't initiate or whatever. So you have to show the examiner that you ask about every single complication of diabetes. Then we will go to the poorly diabetic control. Why? As you said before the end, is it diet related? He's eating without any control. He's not following any diet regime. Or is it related to the medication itself? Is he missing the medication? Is he not controlled while he's on this all medication? So you will think about adding another medication, or you will think about switching to insulin. If he's on insulin, you have to ask him if he's rotating the insulin injection site. All this will be the question to know why he is not controlled, plus the exercise. If he's doing any exercise, at least 30 minutes per day for 5 weeks, 5 days in the week. Okay, Some dermatological complication we know about, skin lesion in the legs. Okay, you can ask or you can find it in the examination. Plus atrophic change in the skin, loss of hair, shiny skin. Okay, diabetic amyotrophy, proximal myopathy. These are minor complications, not common as the major we mentioned already. But you have to ask about stroke, mini stroke, cardiovascular heart attack, retinopathy, nephropathy, and peripheral neuropathy. These are the biggest complication you have to ask about, or the major complication you have to ask about. Okay. In this patient specifically, it was gastropathy, and you already addressed it well. It's related to delayed movement or motility of the stomach, undigested food. That's why you are feeling full, you are even throwing up, feeling sick because of poorly controlled diabetic. What you will do, we'll give you some certain medication. It might help, as you said, it could be controllable, but it will not be curable because still the diabetes, as long as he's diabetic, still you can't control this complication unless he's controlled from the diabetic side. Okay, the medication you mentioned already, or Dr. Intisar mentioned, Dumbedol or prokinetic, erythromycin, and metoclopramide. All this medication can help, and at the end you can do pacing, as you said. This is the case. You address the question well, so you have good knowledge, but try to be fast in the questioning and don't miss the major complication and the poorly controlled reason why the patient is poorly controlled. You have to address this in any diabetic patient. Charcot also one of the complication I missed, but it's related to the peripheral neuropathy. But specifically, it's one of the complication. Okay, Charcot.
Yes.
Okay. Investigation, you mentioned all the management plan. Also, you started with multidisciplinary team, which is very good step because diabetes never will be controlled by you or by one team. It's multidisciplinary, and you can mention all the teams, ophthalmologist and ophthalmologist, nephrologist, cardiovascular or cardiologist, neurologist or peripheral neuropathy or stroke, and also vascular surgery if he has any vasculopathy. So a lot of teams and specialized nurse, as you mentioned, it's good. Diabetic nurse to educate him how to do care of the wound of the ulcer of injecting himself because if you start him on insulin and he wasn't on insulin. So a lot of teams, social worker, occupational therapist, occupational worker. It's multidisciplinary team approach for multi-system disease, which is diabetes. Okay. Any question for this case from Dr. Intisar or Dr. Khalid? Any
No,
question
but
from others?
I think it
Okay.
is better in investigation if we add arterial blood gases and so on.
Arterial, why you want to do arterial blood gas?
Acidosis in the background of vomiting.
So VBG can also help. The
Uh,
venous can show you also the acidosis, right? Arterial, whenever you suspect something related to the
Respiratory.
hypoxia, arterial, yeah, respiratory. But why you break him painful break for
يا خلاص
something?
خلاص
Yes, yeah. Okay.
بي اتش
So,
بي
but
تمرض.
it's good to mention. Yes, it's great to mention because this is one of the possible complication. It's one of the differential as well in this patient. You can say vomiting due to DKA. Very nice differential if you say that. Makes sense for the patient, for the doctor, sorry. And also you can tell the patient that we might admit you to check if you have some complication called acidosis or acidity in your blood. Why? Because of poorly controlled diabetes. The same. Okay. Always keep advising him for the follow-up. You have to follow up with these teams and you have to follow up with hemoglobin A1C 3 months and 3 monthly to check how are you controlled with the diabetes. Okay, doctor, the comment, particularly this patient need admission. Yes, of course, he need admission because you have to check for dehydration as well. From the hand, dry, dry hand, capillary refill, postural hypotension, you have to offer it. Can I check his blood pressure sitting and standing? Check his eyes, sunken, deep sunken eyes, the dry mucous membrane in the mouth, and so on. Okay, you might have also thin skin in the tummy or whatever. Also, as you said, in the frequency, it will be reduced or reduce urine output or reduce frequency due to severely dehydration, also pre-renal azotemia. And also a nice differential when you said, I guess about you, uremic, you mean uremic, right? Vomiting due to uremia or uremic
Yes.
encephalopathy. Yeah, yeah, it could be. It's one of the advanced complication, but it could be also there because of nephropathy, grade 2 or 3 nephropathy, and patient is chronic kidney disease. You have to suspect this. So again, the last uh, time for differential gastropathy, DKA, or as you said, uremic encephalopathy or uremic gastropathy also can be. Okay. Any other question? GERD also we can put as differential here because most of these patients having also GERD, esophageal reflux disease. Any question? Any comment? Dr. Insar, Dr. Khalid? By the way, well done,
Thank
Dr.
you.
Khalid. As first time, I think you didn't practice with us before, right? You
Procedure
practiced before?
long time, yes.
Long time, yes. Okay. But well
Thank
done. As diabetic,
thank
I
you.
guess you will not forget these complication again whenever you
Yes,
face diabetic
yes,
case. By
for
any
sure.
presentation, yes, you have to ask all these questions.
Sure.
Okay, thank you. Any Dr. Ansar, you have any question? Any question from others? Uh, we apologize for the communication, so we'll end this session now. We'll see you tomorrow, inshallah. If no more question, we will end it now. Thank you all. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.